say anymore, and you can tell them more about yourself. So
Great. That sounds good. Thanks, Marla. I'm keeping the mic down low enough so it isn't like a rock concert in here, so let me know if it is too loud. So again, thank you for having me here today. And yeah, this is my second year on faculty in family community medicine, and I have quickly learned that once you dive into a topic like this, it is both exciting and nerve-wracking at the same time, because there are millions of paths and connections that you can take. So I will try today to condense all of the interest and information into 55 minutes or so for you here. So just a little bit of background on how I got involved in the area of caregiving and dementia. Really two main things kind of brought me into it. I did my PhD at the University of Minnesota, and we had a trip in our gerontology course, and we went to a nursing home, and we were able to tour through it, talk to some of the professionals, talk to some of the residents there, and I got in some terrific conversations early on while I went over there, and those 10-minute conversations turned into about 3 hours. And before I knew it, the bus was leaving from my class, and someone had tapped me on the shoulder saying, "Max, they're leaving right now. Like, you can't talk to any more people. We know you're really engaged." But I had some fascinating conversations just in the lobby, and really gave me a different perspective about dementia care. We think so much about individualized care and treatment and what we can do for the patient, but really today it's talking about how we expand that further, really to the family, community, and a broader system. My second experience was working in tertiary care at the memory clinic at the University of Minnesota. I got to sit in with the doctor and the consulting therapist, along with the care coordinator. And I have my colleague to thank for sure there, Janet Yates. And she brought me into the whole world of how do you talk with the patient and caregiver around delivering a diagnosis, working through a treatment plan, really getting the caregiver and the family on board. And that really, really opened my eyes as far as this whole new world, that really this is a systemic issue. And if you're working with this population, you have to treat the family as a system and unit of treatment. And so again, that just really changed my perspective throughout all of this. So I really have those to thank, definitely in my journey going forward. So really the main things for this talk today, hopefully the clicker will work, is to talk about some models, a few things that you can conceptualize when you're working with patients and caregivers around the course of dementia, and really to look at both how life cycle stages and models and phases of care really come together. Talk about some treatment and skill approaches. I know everyone loves hands-on learning when they leave here, so what can I do now when I get in the room? What are some skills right off the bat that I can use? And then a list of things to keep in mind when you're talking with caregivers in any type of setting, in any type of care there. Just to go through some of the statistics. Again, a lot of these are pretty repetitive, and I'm sure many of you have seen these at several dementia talks. A couple key things here. The amount of hours that caregivers spend and dedicated, and on top of that, the amount of financial resources or lack thereof that they're getting. One of the big things that I see both in my practice and when I'm touring through the hospital is the amount of unpaid time that caregivers have. And this is such an enormous problem, not just from a physical and mental health standpoint, but who's really coming into the care for the family. We can't only look at the caregiver as one singular person. They're also really connected to their community, to their other family as well too. Average family caregiver spends more than $5,000 a year caring for someone with Alzheimer's. I'm sure when that stage even gets more progressed, that number definitely skyrockets. 3/4 of all caregivers, and this is according to the new data from the Alzheimer's Association, state they're at least somewhat concerned about the future of their health. And that's so important. There's a lot of research on caregiving that's sorely needed. Again, the work that we're doing with cognitive stimulation therapy, including family, including caregivers, more psychotherapy approaches, more ways that we can use caregiving-based support in integrated care. We need to do more family-based research. And the bottom one, 28%, have been caring for a loved one more than 5 years. So this is also a very long-term process. A lot of times in healthcare, we make the mistake of we give the caregiver some resources at the first couple sessions. We let them be. Good luck. You know the tools. You have the protocol. We'll see you later. It's really in that later chronic stage of the patient where we have to address more patient care and really look at what family resources are coming into play. So the broad, hopefully that's not a page you're about by accident. The global impact of dementia, this really hits on, and again, repetitive data, the prevalence worldwide. So, we tend to think of this just as a huge a chronic condition in America. The light green shows the prevalence in continents, but the top darker green, which I know the light can't see too well, that's the prediction of how much is going to increase by 2050. And so you can see in almost every single continent, Europe being close to double, it's going to at least double. And I think that these estimates are even pretty conservative given some of the trends and statistics we're going. I talked to research colleagues that I know in Singapore and Hong Kong, and they say numbers are not only skyrocketing, but there's almost no family-based care in the primary care clinics, internal medicine, anything. So countries and continents are really lacking there. And the age, even for Alzheimer's dementia-related caregivers, this is really interesting too. We think about this being 65 and older, being, I guess, the stereotype maybe in our society, it's older caregivers that are the primary people looking after care. But this is really interesting too, the under 44 and especially the under 35. You think about young adults and how many obligations with work, the sandwich generation, how many responsibilities we have. And where society is going and trends and generations, I see a lot of millennials in therapy, and I say, would you be willing to caretake for your parent, for an aunt, for an uncle? A lot of them have mixed opinions, and the spectrum is really varied. And so really it's a question of how are we adjusting based on generational themes of caregiving, because as this trend continues, there's going to be more in this range that's going to have to decide, how do I balance family life? How do I balance caregiving? And when that stress precipitates, it can really affect the patient's health. So again, keep age in mind, especially when you're working with them at this stage. How many of you are familiar with biopsychosocial approach in care? Several of you. Few hands, okay. I know Engel was from way far back, but this is even 40 years ago, and we're still talking about the same things that we need to be doing in care, and we're really highlighting this. I stress this so much to family medicine residents. You have to look at the BPS model. You have to broaden your spectrum looking at chronic illness, and sometimes they still go back to biomedical model. But he really highlighted, this framework, and when we look at chronic disease, especially dementia, you have to look at the social, psychological, and community determinants of health. So you have to broaden the perspective. We have to look at this as a humanistic form of care. We can't just see this from a technical perspective and see how are we addressing medical issues and even translating that over to the family and expect them to know. We have to see this interconnected in a systemic way. And even said too here, provide the basis for understanding the determinants of disease and arriving at rational treatments and patterns of healthcare. Again, this was late 70s. We have to not only see the medical model as being biomedical, but looking at the patient, the social context, and the complementary system in society. So again, the question is, 40 years later, how much of this are we actually doing in practice? How much is actually on our minds of when we have a 20-minute appointment and even a family member is in the room, do we allow for these questions? Do we allow for this assessment? Do we build caregivers and families into treatment plans? I don't think we're nearly doing enough across all disciplines, and this is what we're really trying to hit on here, and I'll stress on it more. So we always talk about the physician-patient relationship, but in the context of dementia, I open it up to two other categories as well. How do you view the context of illness in the patient and family's life, and what context does the family play in treatment. So you have to look at, I know this doesn't even show up well in the light, but again, all these 4 parts are interconnected. When I work with residents, I say, what questions are you asking of what meaning-making patients are making in their life about their illness and the phase of the illness that they're at? And as far as the family looking at that, how do they define illness? What's the family history of dementia? Do they have a specific framework of how they're going to caregive? Do some people not really know much about it? It's seen as a death sentence. Are other people really comfortable in saying, there's multiple people that we've caretaken, this is just in the long line of things that we have to do? So again, look at that spectrum. Don't only look at the physician-patient relationship, especially with this. I have to add kind of a slightly funny cartoon here, but again, make sure that you just go beyond just the normal advice when you're giving information to patients. Hopefully you're a little more caring than this guy. I trust that all of you are. Before I kind of get into the models, maybe I'll just throw out what's the most difficult aspects when you have family members in the room, or for those of you who have worked with patients with dementia, Alzheimer's, any type of dementia-related disorders. What's the challenge when you try to incorporate the family or you're working with caregivers in general? What's been some experiences or statements have been challenging? Yeah.
I'll say I just had a family meeting about putting a feeding tube in a dementia patient, and I just feel it's really inhumane, and the patient's suffering, but the family wants the patient to live at all costs.
Right.
So it's like, how do I go home and feel good about that I'm taking care of the patient appropriately?
There you go. So you hit on 2 things: the discrepancy between what the family wants and the patient wants, and then it's kind of the self of the provider. What are you bringing, taking home? Did you do the right thing? Self-doubts. That's great.
So we had an interesting dynamic class, and we see this a lot. So mom is, the matriarch in the family, lots of daughters caring and watching for her, but trying to get them to understand that she can't pay her own bills anymore. They need to step in and start taking over some of that sort of thing, and then not really wanting to go there yet, or it's just uncomfortable.
Yes, absolutely. And I assume that maybe that talk in itself was not quite comfortable around finances and money.
Right.
Yeah.
So they could see that in the exam that she couldn't draw a clock, she couldn't do any of the
Yes, absolutely. And things that you may think are not kind of necessarily protocol of a visit, that's absolutely crucial, because the less that caregivers have to really take as far as tools and tips, I mean, these are real life, everyday things. Finances, driving, advanced directives, all this stuff. A lack of information, it's only going to cause more stress in the family going home too. So those are good ones. So I'm going to talk briefly about a few models to kind of look at. And the main thing today is to shift your perspective just a little bit on how to intersect questions. It's difficult even to formulate questions when you have caregivers or family members in the room, because you're thinking, I have so much to cover here in such a short period of time sometimes. So I got trained in my postdoc under John Rowland, and he has a great typology model around chronic illness. And this is something that a lot of therapists in geriatric work are starting to use now. It's really looking at the time phases of illness and really determining the set of questions that you ask caregivers or families based on where the dementia is in the patient's life. So if you're looking at, let's say, this crisis stage, so right after diagnosis, and I'll get to a study that we did in a little bit, which the reports are fascinating from caregivers, right after within the first 2 years. So, and immediately, even when the caregiver's given the information, your loved one has dementia, your loved one has Alzheimer's, just the shock and that delivery of diagnosis, asking those questions in the moment. What meaning are you trying to make? What's going through your mind now? What world and what sense are you trying to have? But especially within the first 2 years here, it's making sense now of their lives and knowing they have to drastically alter their family system, their lifestyle, perhaps their job roles. So all these questions within this crisis phase is really, really important. And again, this crisis phase goes just beyond that first visit. You know, areas of stress, anxiety, depression, even early burnout can really happen at this phase. So don't overlook after 1 or 2 appointments that you're really getting through some of these questions. It's very important. But as caregivers go through kind of that 2-year to 5-6-year period, even longer, we call this the long haul, the chronic phase. And this is often the most overlooked phase when you're working with families. So it's kind of the assumption it is what it is. They're doing routine work, kind of same old, same old. But we're starting to see a lot more mental health issues surface during these years in research. And so a lot of the questions here, which I'll get to in a little bit, is how are you continually motivating yourself to be a good caregiver? What strengths are you still finding in yourself to keep going? Because burnout can happen where the rubber meets the road. If they don't have support or resources at this point, they can be in trouble. And when a caregiver's health really runs into the muck, bad things can happen. At the pre-terminal, as this becomes very advanced, you start to see transitions into long-term care, nursing home. Now questions become, are family on the same page about this decision? Is the caregiver equipped to still kind of make meaning of being a caregiver while letting up some of those kind of control responsibilities with their loved one at home? I was working with someone in therapy, and her husband had dementia for 10 years. And she said that the toughest thing in the last 6 months was knowing that every single day I couldn't at least touch him. I couldn't at least put my hand on his shoulder. I couldn't kiss him. I couldn't be there, the proximity. I had to visit him at the long-term care facility, and that was the most difficult thing. I could still interact, but it was the physical proximity of being there that was the toughest thing to let up. So again, the main thing is that all these phases, there's certain questions that we can ask, but it's not a one-size-fits-all. You have to look at how this intersects in conjunction with, I don't know how many of you have heard of family life cycle stages. Some of it is kind of being revised because obviously family dynamics and situations in society are adapting too. But as family life cycle hits across those stages, you can see where caregivers in a young age versus those empty nest or later life, you're going to be asking different questions. So someone who's younger, you know, it's going to be more job responsibility, balance, you know, having young kids. What is this like for you? Empty nest and later life, it's a lot more of those more intimate, formal questions. And because you're spending more time at home, or you're having more hobbies or more things that you're having to replace in your life, again, it's going to be a different set of circumstances. So really looking at how these two things intersect is really going to frame a lot of things that you're going to be asking. And here are some typical questions that I often like to ask when I'm working with patients. So how did you react to this news? A very simple question, but again, we often don't even ask the simple ones of just a reaction. Someone says, I'm expecting this for a while. I knew it was bad, but just hearing the diagnosis was a really big shock. Who did you include in the diagnosis? So a lot of families will say, we're an open book. We're going to allow this and talk to everybody versus, you know, we're the Wilson family. We're keeping it within this family. We're not talking to anyone else. There's a little bit of shame or there's a little bit of stigma even putting that out there to our friends. I've worked with a lot of patients where when they go to parties, there's even shame of bringing their spouse, bringing a loved one with them, kind of in fear of what's going to be unfolded, what symptoms are going to kind of manifest. The third one's probably the most important too at this is what meaning are you making of the diagnosis? And the sad part is not enough physicians are even communicating that there is a diagnosis in the first place. And again, I'll get to some of the research on that in a little bit. So it's really getting the qualitative story at this part. It's really making sense and saying, you know, I'm confused, I'm really stressed, I'm really frustrated that no one's here to help. I knew that this was going to happen. It was just a matter of time. Now how am I making sense of my life as a caregiver? So great questions. Future focus question, how will this look moving forward? Another good one too. Clicker. At the chronic stage, some good ones too. As I said, despite some symptoms that may be worsening, how are you making sense? How are you making meaning? Do you still feel like you have some control over what's going on in the current situation? Again, when caregivers talk at this chronic stage over lack of control, it's the thing of, I know it's getting worse. There are some things I can still relate to Dan on. There's some things that I've lost Dan completely, and I know that dementia's taken over on that. So it's the divide that starts to happen, and it's acceptance at this stage that's really important for caregivers to get meaning of that acceptance, because there's always that acceptance of grief and loss at that point. How does the family continue to interact and communicate despite the course of dementia taking place? So I always tell family members, keep talking about this. You're never pressing pause for several years and saying, let's get back to this when it gets worse. That's one of the most dangerous things I see families do. Things may progress so much quicker, and all of a sudden we have to make living arrangement facilities for this person, or there could be other health issues, frailty issues, things come up. And then unknown thoughts, feelings, fears that you hold around dementia. This, at this stage, is really where people start to kind of have confidence and meaning in themselves of, I can now express and kind of put hold of what I'm feeling. Or even in that crisis phase, I can look back and say, you know what, I was frustrated, or I was anticipating this. I just knew I had to take control of it. Whatever emotions or expressions are taking place there, a lot of it comes out at the chronic stage there too. Okay, my controller's going totally haywire, so we'll just do this. And then at the terminal stage, so, right before long-term care, late months, even days of life, this is where you really talk about fears. You talk about that sense of loss. I know Dr. Morley this morning talked about death and people being comfortable around talking about death. I often train therapists and tell them, you have to talk about this, especially if it's at this phase, and residents likewise. You have to see how this is anticipating for the family system. How is the family redefining their roles at this final stage too? So this is going to change quite a bit. Some family members may want to come in town, pay their respects. Some family members may feel like now this is the only time I have to really step in and be the caregiver or make final decisions. This stage can get pretty ugly if advance directives are not seen early on too, and give a couple examples later on as well there. Any questions so far on that? Make some sense? Okay. Next part, kind of just the skills and practice. So it's kind of, all right, I have a model, I have something going on here, but how do I use this? How do we get the ground running? Many of you may have heard narrative therapy or narrative techniques, narrative medicine. I think that this is a great approach, and this is starting to be in the research quite a bit. It's really a postmodern approach that's looking at how do we externalize a disease or an illness outside of a person, out of a family, out of a system. And I think it's so valuable because one of the hardest things working with this population is that families will oftentimes be so mad at their loved one, and I tell them, be mad at the dementia, be mad at diabetes, be mad at cancer, but you have to be able to take that out of the person. I say the person is not the problem is the problem. And the more that you can convince caregivers and family members to think that way, they're going to have some acceptance and relief that they can separate those two things. So language is certainly one thing. So talking to caregivers, talking to family members, using that externalizing language. I often say, how did dementia have a hold of the family this week? I didn't say what was wrong with Don's problems. How was he kind of resisting you, battling you. Okay, that way I'm putting all the pressure and blame on the patient. Okay, so I look at the disease as having a full effect on the family system. Great way for caregivers to really separate that. Diaries and free writing. I love doing this. So, caregivers will get a journal. They'll do free writing. They'll talk about how they're mad at the dementia and how they're trying to fit their role in their life in the context of this. There have been some amazing writing samples. One woman I know is doing like a chapter 6 of 20 right now. Maybe she's going to be writing a book on it. Maybe I made her go too far. But she is kind of hell-bent on doing that. So again, it's a very good experimental exercise to get caregivers going on that. And likewise, how do you find intentional times to get mad? I often tell caregivers and family, allow yourself to have those negative emotions and feelings once in a while. You can't bottle those up. You can't expect to be on as the caregiver all the time. You're going to have down periods. You're going to have times where you're off. So how do you get mad? How do you get frustrated? But again, externalizing this outside of it's really, really important. And then some narrative biographies and stories. More narrative medicine type where caregivers have started to do this, working with their physicians and being able to check in more and more, kind of self-stories so that they can revisit this with their doctors. Really great ways to include more of the family and caregivers. Another thing, family genogram. I'm sure some of you have maybe seen this, the graphical representation of families. Whenever I teach this in class, I'm always frightened because I know I'm going to make a few mistakes on symbols and look bad in front of students, even though I've seen the book 1,000 times. So this is really a graphical representation of really 3 generations, but it can be more, and such a valuable assessment and treatment tool looking at the context of dementia within a family system. What's the history? Are there patterns? Are there linkages that are seen there? This was a case that I saw in my postdoc work. And you can see on the right this whole row of circles. Those are 3 generations of only child daughters. And the second to bottom was the main caregiver that I worked with. She was taking care of her mom above, who had early getting into mid-stage Alzheimer's. Mom was depressed, past alcohol abuse. So I was working with the grandmother, the mother, and for a little bit the daughter. So there was 3 generations of only children. You can assume how enmeshed this family was. They were all living together. The grandmother was actually in a side-by-side place, and the poor husband, he had a self-business, and I'm sure he says he wants to help out when he can, but I'm sure he wouldn't mind once in a while kind of drifting off at work for an hour or 2 more during the day. So you can see here kind of this context, and it was very, very difficult because I got to kind of see this pattern even from the grandmother's mother when there was some emotional abuse and there was some issues with communication. That trickled down to the grandmother and mother, and when they had some fights, they had some resistance, I could go back to the grandmother's past situation with great-grandmother and say, were there any themes or patterns that continued? And we worked off of this, and it was incredibly effective. I talked to family medicine residents on inpatient rotations that once in a while they do this, a very abbreviated one, but we're really having them learn kind of a quick 5 to 10 minute sketch. How can you get a quick family history or a snapshot? Keep that in the patient's file so that the therapist or social worker, case manager, physician can look at that and check back in. So again, that's just one example, but a great skill and assessment technique that you can use in practice. I'm sure many of you have heard motivational interviewing. I always like to say, whether intentional or unintentional, I think we do this at some point in our practice. I think it's a great strategy and great technique. With motivational interviewing with caregivers, it's a little bit different because where we see kind of this pre-contemplation, contemplation stage is the motivation to continue to caregive and to have confidence in yourself. So this is kind of a self-esteem, kind of stress reduction type of management to use, and it's very, very effective. It's much different than substance abuse or depression or someone with eating disorder symptoms. So you're not getting them maybe past a necessary reduction, but in this case, you're really motivating them more to assume this role. When they get to the preparation stage, what things are they hoping to do? Are they kind of doing small things for the patient as far as finances or activities of daily living? And then when they really get these things into action and in maintenance, now they've really developed a routine. And that's really the overall goal, is how can you develop a common routine for yourself that's going to work for you, that's not working towards a protocol, that's not working towards what society's telling you to do, that's going to work the strengths for you. So again, I continually talk to them about that wheel, and sometimes there's a quote relapse. It doesn't happen too much, but again, you can use some of these phases and stages when you're working with them. Okay, so before I get into this, I'm going to show a video clip now that you have all the information about caregivers. This was an APA video. Sarah Hahn Quayles, she does dementia caregiving family therapy. And so I'm going to show about an 8-9 minute clip. I don't know if we can hit some of the lights. Maybe it's going to be easier to do that. Do we have something? Oh, there we go. Perfect. So in this clip, now it's really dark. So in this clip, we're going to see just a background of the patient. This is a psychotherapy visit, but she saw her internal medicine doctor and learned more about her mother's condition. And the main thing to pay attention to, not just kind of the technical stuff, but really what the caregiver is going through, her context. So think back to the family life cycle, those crisis, chronic, terminal stages, and kind of see where the patient's at. And then I'll have you talk for a few minutes on, if she were to come to your office, what would be some additional questions you would want to ask her, based on maybe things that her doctor was not able to cover.
Alzheimer's, and has been diagnosed for a while.
Right.
About how long has she been diagnosed?
For about 3.5 years now.
And how did she get diagnosed?
I noticed because my mother was a sharp individual. She was a retired teacher. Well, she hadn't retired yet, but I just noticed that her finances started to slip, and she wasn't as energetic and outgoing as she had been. So I didn't know it was Alzheimer's. I assumed I knew what it was. Figured she just needed to retire because I told her previously that she should retire years prior, but she didn't want to. And my sister that lives in New Jersey came here to visit just for a couple of weeks. And she said, maybe we should just go have mom tested to see if she has Alzheimer's. I said, oh, okay, but my mother wasn't willing to do that. So we mailed a lot in order to get her to go to the doctor. And she was really agitated. She wasn't willing to go. But she ended up going anyway. And later on we found out that she was diagnosed with Alzheimer's. Early stages of Alzheimer's.
Well, let me back up and just ask you a question about that. You said her finances started to fall apart. How did you know that?
Because she paid all bills on time, and because I was the youngest child, and I stayed home longer than my other siblings. I just kept up with things that she did with her finances. And there was one bill, it was a credit card bill, and she was late paying it. She had never been late paying anything. So when she was late paying that bill, I just assumed right away, okay, something is wrong. I wouldn't imagine Alzheimer's or any form of dementia, but I just assumed, I thought maybe she was just tired and, she just didn't want to work anymore, but didn't want to stop working. And that just triggered something with me, that one late bill.
Wow. And was there an ongoing pattern from there of other problems, or did you just go ahead and step in at that point and help her?
When she was late paying that particular bill, I knew something was wrong, and she abruptly retired. It was 2001, 2002, it was 2001. In March, during her 5th period class, and my mother was an English teacher. During the class period, in front of the students, she said, okay, I don't want to do this anymore. And she walked out of the classroom, and a friend of hers that was also an English teacher entered her classroom and said, Miss Robinson needs to go to the bathroom for a minute. And she said, I want to go home. I don't want to do this anymore. I'm tired. I can't concentrate in the classroom. And she left. school early. Then, she may be sick or something, so you need to go home and just go check on your mother. So I went home and she said, yep, I left. I didn't want to work anymore. I couldn't do anymore. I felt like I couldn't think straight. And that's it. Like, no questions asked.
What did you do?
I think that day I called my sister that lives in New Jersey. I told her what happened. And I said, something is wrong. Mom's mind is not the way it used to be. And I think she needs to go to the doctor. So I took her to her internal medicine doctor, and she's the one that suggested, maybe your mother needs to be tested for some form of dementia. And she suggested that we go to Rush Hospital to get tested. Yeah, so her internal medicine doctor is the main person first person that, said that she should go get tested.
Okay. So that all happened about 3.5 years ago?
Yes.
Okay. And so once she was diagnosed, then what happened next?
She didn't accept that she had Alzheimer's, that she's in early stage of Alzheimer's at all. She just assumed she was getting forgetful and she was, getting tired because of old age, attributed to old age. So for many months, I would say for a good year, she would always take her medicine, and right away the doctor put her on Aricept. She didn't want to take her medicine, and she didn't want to hear anyone mention the word Alzheimer's or that she was slowing down in any form or fashion, and she still wanted to have her hands on her own finances. And at that point, I wanted to have power of attorney over her finances, but she wasn't willing to do so. So there were times she was late paying her rent, and I tried to step back because I knew she still wanted to act like she had control of everything, even though I knew I had to intervene in some form of fashion. But she still wanted to handle finances, she still wanted to pay her rent, and she was late a couple of months. She got some notices, and the management office called me because one of the ladies that works in the management office, she's known her for many years, and she said, your mother's been late a couple months for her rent. I don't know what you all want to do, but so this doesn't happen continuously. You need to step in and do something. And she knew she needed.
I'm going to skip a little bit here.
For so long. So I really wanted to move to New Jersey. I want to stay in her apartment. Even now, other relatives, friends have said, and she hasn't wandered, she's not that far off yet, has said, why don't you think about putting your mother at home or having her live with your sister in New Jersey? And I said, I don't want her to move from this apartment until, one, I make a decision, and I think that she is not capable of living here with someone else or killing herself. But I
lights again, if you don't mind. So you have a little bit of context now as far as with this caregiver, so some information. Maybe just talking, maybe a few people next to you, if she were to come into your office, and let's say maybe she were to bring in her mom too, what would be some questions you would want to follow up with this person on? So caregiving questions, you got a little bit of the scope with the family, you got a little bit with the patient's health, kind of where they are, with the illness about 3.5 years in. So maybe take a few minutes to talk, and then we'll come back as a group and kind of discuss some thoughts on this. All right, I know that was a quick couple minutes, maybe long couple minutes. What were some conversations or thoughts you have as far as maybe topics, questions, areas you'd want to explore? I know it was a really short 8 minutes or so to get a brief history about this caregiver, but what were some of you talking about?
Is she married? Or have a partner? The daughter, what is her psychosocial?
The daughter is married. Yes.
Figure out, is the patient living with someone?
Yeah, the patient right now, the daughter, the thing I skipped over, the mom was living with the daughter for a little bit.
Okay.
And so it was the determination that with her being very stressed as far as what to do with mom, to put her back into an apartment. You heard about the sister in New Jersey, but with some issues going on there. So that was a determination. That was a problem.
Mental lady just living alone by herself?
As of right now, at this point, she was living with the daughter.
Okay.
Right,
Okay.
right. The question was, going forward in the video too, was it was a very stressful. What do I do now? I know that symptoms are getting worse, and yeah, that's certainly something you could touch on in a visit.
Who else is
It's her husband, and one child.
Does she work as well?
She works. She's in healthcare. I forgot her job that she's in, but she is a pretty demanding. Oh, a teacher. I'm sorry. Yeah. Yes. She was a teacher. I'm sorry. Yes. She.
Really pissed off at the middle sister who's been incompetent in getting all the attention
Right.
all of her life. Now she's stuck with mom and she can see it coming.
Right.
She's going to get stuck with this sister. And mom liked the middle sister better all along anyway.
Exactly. Right. So let me ask, what would you ask or want to bring up, knowing some of this information? Or
So the social work contingent over here wanted to ask her how she was feeling.
okay, good, good area. Yes. Again, I mean, I think she's at the point now, even almost 4 years into this, of being pretty burnt. I may not have shown this at the beginning of this video, but I mean, she has a lot of difficult decisions to make, not only with her mom, but within her family.
And she'd have to be asked that because she doesn't look it. She looks all together and really not, she really does. She's still holding it together. So sometimes when people are like that, you really have to ask those questions.
Exactly. That's right. And at face value, especially in a very short appointment, you're not going to get someone who's really going to be very verbal about that right away. So that's good. And anything else as far as I know it wasn't a ton of background history on it, but anything else as far as other questions or things you'd want to explore more on?
May I ask a different question on the topic of this?
Sure.
So something that I struggle with a lot, that my colleagues are actually helping me with a case that is a good example of this. That idea of the timeline. I find that crisis tends to be more towards the end when, and no matter how much preparation I kind of give in that period of where things are going okay, and they have their nursing home set up and they have all this stuff in place, I still struggle with that period right before their terminal or the crisis phase where they were all of a sudden now, okay, it's time, but then they end up in the hospital before we figure out it's time.
Right.
Something really catastrophic happens. So I struggle to know what, and I don't know necessarily how to answer that question, but how do we make that transition better to kind of move into the terminal phase in a more gentle way, as opposed to waiting for that catastrophic moment where somebody wanders away or falls and has a hip fracture or something dramatic that says, okay, now it's time to go to nursing home.
Yeah.
Things were going fine until that day.
I would say the overarching answer would be do everything supportive throughout at the beginning and every phase before you get to the terminal. But I think there's also the difference of these phases for the patient versus when a crisis phase for the caregiver. Could be multiple crisis phases. And so again, even though this is based more off of the disease for the patient, you're right. I often see that there's kind of multiple relapses of crisis that happen based on areas of transition or areas that come up.
Because they're doing okay until it gets hard.
Right.
They often end up in the ER instead of.
That's a great point. Yeah, and I don't have a breakthrough answer on that. That's a great question. I think again, it's continually to check into and to reassess at these visits of what stress they're going through, what's really going on behind the scenes. Because if we don't ask those questions, we're not going to know if they're at a crisis point.
Oh, I should say, Sue and I did a study some years ago of people who were done caregiving because the person died. And one of the things that we were kind of surprised about came up was that during the phase you're talking about, they were hoping people would die. And then they felt guilty about wanting them to die. And then they did die, and then they felt guilty because now they're relieved that they died. So some of that may be the back
Yeah.
certain things that are gonna happen that we get ready for?
I think future-focused questions are incredibly important. I think how you phrase it is really the key. At least, and I haven't had too much as far as in the cancer realm with questions like that, but I think not putting in as much prediction scenarios, but more of what ifs and kind of planning. So what if scenarios, let's say you're put in this role where you're taking on these 3, 4, 5 obligations, or you have to be the main person responsible for all the providers in care. What could this look like? Or have you envisioned this? So I kind of make it the perspective back on that to really create in their mind that scenario. I mean, that gives a lot of information to me, knowing I'm sure they probably have thought about it. Actually expressing that or able to verbalize it's a lot different. So again, that's just one approach. I don't like to force and say, let's go through 4 different scenarios here and let's see what's going on. I usually, after the first or second one, they'd be pretty stressed and checked out and exhausted just going through them.
Well, if I had a patient 58 years ago, his wife had read these stages, through the Alzheimer's Association. She came in with all these papers. She showed me, she says, I knew that when he walked outside his underwear, it was outside his pants. I knew that was stage whatever. And she wasn't shocked at all.
Yeah. Exactly. Yeah, and I think, again, that's the amount of knowledge and preparation that some people have versus when it's a total shock, it's kind of reincorporating that education about it. So, again, this model is not only around the disease, it's around education, too, for caregivers of how much they need to sometimes know.
If we had predicted people are going to stop eating, you wouldn't have to deal with the feeding tube as much. They're going to fall and break a hip, probably.
Yeah.
What are the odds? They're going to forget who you are. What? No, they're not forgetting who I am.
Right. Yeah, it's difficult. It's a balance between things you anticipate, versus I'm going to give you absolute scenarios that could happen. I think there's kind of the differences. So.
Well, also, what I think of when you're saying those things is the perception of timing. I think families always perceive it will take longer than it will. Sometimes I think it's the opposite. Sometimes I think it takes so long. That's the problem with dementia. It really is hard to put a timeline on it for them, right? I mean, it's not, depending on their other comorbid issues,
Yeah.
I always want to know how long. It's really hard.
Yeah.
What you guys say to them, but I mean, I'm dealing with combination because they seem to always be shocked when they're not recognized. Yet they tend to come back from the dead so often. That then they think, oh, if you just give mom that antibiotic, she's gonna be fine. Yeah, and it's because this happened 5 other times and went to hospital and that was 5 years ago and they told me she was gonna die. So I think it's combination.
Yeah, which is a good point, which is a great transition, or I'm making the transition. So whether it was a nice one or not, that was good conversation. I appreciate it. I'm aware of time, too, to get the last couple slides in. But you're right, time comes up, and this was something where we ran some focus groups of early Alzheimer's caregivers within the first 2 years from a diagnosis, and there was some really, really deep information that they shared. This is not a picture of the focus group, by the way. But there's several topics that they touched on that were really important, and a few may be commonplace, but the top one resonated with 9 of the 13 participants did not receive a formal diagnosis at the time when they should have. And so that's really, really scary because it's not only missing that information or kind of that determining factor of my spouse or my parent has this, but also that communication and important conversation that the physician should have with the caregiver at the time and the patient. So that was a really, really resonating theme. Medication management was also a really big thing too. They say I realize with Aricept or Namenda or any of the inhibitors that I'm aware of their schedule, I'm aware of everything, but with side effects, how can I determine if I don't get any information from the doctor directly or nurse or whoever, if this is really the medication, if this is something to expect, if this is just my spouse being grumpy, irritated, or just depressed at life. And so any of those scenarios they were really, really confused by. And they had some really good talks on that. Getting a second opinion. The real big thing they talked about in getting another opinion from a doctor was as much they lacked a supportive personality from their healthcare provider or their healthcare team, as much as wanting to really confirm that a diagnosis was there. So again, some of the more humanistic qualities they expected out of physicians, they didn't get as much. I will say though, I was pretty confident hearing at least those from SLU. It was positive. So anyways. And then needing more information about outside services, so support groups, community services. Again, not that you want to force feed a lot of that within the early months, because a lot of people aren't ready for that yet. But at least some information or some connections. Again, even to give some information from the Alzheimer's Association, just some packets, some information, have things readily available. They were really, really disappointed as far as some of their care providers not connecting early on in this process. So really keep that in mind. Obviously not just with patients, but when you have family, that is absolutely so critical. That's something they really need from all of you. Last slide to wrap up. Again, this is just a review of some main topics to keep in mind. And I know this covers a lot of different talks that Grand Rounds will have. Information about the diagnosis and medication, again, as the focus group shared. They always need information. They thirst for that. Areas of support. So again, the assessment of how are people interconnected with their family, with their faith community, with their neighborhood, other people. How are they getting support? How do they have other outlets? It's really important that they have even a light hobby, even if it's twice a week that they can get out and walk, or that they're able to get a good book to really escape. Something simple. It doesn't have to be a regimented hobby to really escape from this role. Really, really important. How caregivers roll with the resistance, as we call it, and deal with denial from their loved one, because a lot of those are going to come up, feelings and whatnot at the beginning. Mood issues from the patient, again, how to discrepancy of, is this medication? Is this the course and progression of dementia? Is this just the person that I'm living with at the time? Someone talked about financial decision making. Again, finances should definitely be at some point in discussion. Driving and safety issues. I'll show a few website links that are really helpful. Very, very important conversations. Advanced directives. How do you plan early? I always tell residents, and it always freaks me out when I do inpatient rounds once in a while, is someone over 70 with dementia in the hospital, and still a few of them don't have an advanced directive. And the family is there, or the caregivers come into the hospital. I tell the resident, make sure you're on that right away. So keep that in mind. Burnout and burden, as many of you said, there's going to be different points and stages when fatigue, burden, burnout hit. It's not a question of if, it's when. So how do you work with that's really important. And then obviously transitions to different living facilities, very, very important, obviously, to have those talks when it's at that time. A few great books that I'll just show you real quick. Pauline Boss coined the term ambiguous loss. Really, really applicable to dementia. Loving someone who has dementia. I give this to a lot of caregivers, and even for providers, it's a great book just to learn about the world of a caregiver, all the different topics to kind of take charge in that role. The Emotional Survival Guide to Caregivers by Barry Jacobs. He has a quote in here. I thought that was a really good summary of this. Many of us carry in our minds a kind of platonic ideal of what a family caregiver should be: patient, generous, strong. Very few of us can perform superhumanly for years on end. Only our ideals to propel us. So again, this really shows that caregivers can go only so far before a wall is going to get hit. And so we can't assume that they're going to have all the resources, send them on their way. You need to continually check in, and he has some great points in the book to touch on. These are some final resources to keep in mind. Again, I'm sure all of you or most have looked at the Alzheimer's website. I think it's great, and St. Louis has a wonderful chapter. I'm really impressed. I've lived in a ton of places, and I think St. Louis is definitely one of the strongest as far as associations. ARP, the Hartford, when you talk about driving safety, they have some really good manuals. And as far as any assessment for stress, the Burden interview, Stephen Zarrett, some other researchers too have some really good instruments and tools too. So hopefully after this talk, you can at least have a different framework of working with caregivers or family. Again, some of the main things, just remember where they're along that spectrum: crisis, chronic, terminal. And really keep in mind, are you using a humanistic view when you're working with families? Everything also is systemic. If you think of dementia as individualized, you're missing all these parts. You're missing what that caregiver talked about in the video. So make that change today. Thanks.